Yes, the fab. We are recording this video, thank you, Alex, and we'll be sharing this later. So, Katrina, it's all over to you.
So, what I'm going to just quickly go through really is, can everybody see my screen? Can, lovely. Just so define what critical medications are. Our project so far, because obviously it hasn't finished, it's going to be an ongoing project. What we actually did, and then our next steps going forward, and then obviously a chance for any questions, hopefully. And the reason that we've sort of joined the Fab Day today is that really for me this has been a really lovely piece of work where we've seen really fabulous engagement from our fellow colleagues across the organisation, particularly our pharmacy colleagues, but our medical colleagues too, and of course our nursing colleagues. Obviously critical medications, you know, is a key work stream for me as a quality matron within our organisation, and so we've been working for quite a while on this project. So, and to actually then start to see some successes, you know, is really sort of inspiring. And obviously, the idea of today is sort of around changes that we've made and successful changes. So, you know, I'm really proud of my colleagues. So the aims and objectives then is that we're going to just look at what critical medicines actually are, the project, what we've done, and then next steps. So critical medications are drugs that must not be missed or delayed, and if they are omitted, they can have devastating effects on our patients. So we all know that obviously, you know, there's key medications that are fundamental, that if we are late with those medications or delayed, we'll have very quickly an impact which may be devastating on our patients. But do we all know what all those critical medicines actually are? You know, and I think I don't think any member of staff knows every medication inside out and every interaction. Obviously in our day-to-day lives as practitioners, you become very au fait with medications that you use regularly as part of your, you know, your normal care pathways for your patients. But obviously sometimes there are patients that may be admitted with medications that are less familiar, and do we actually know if they are a critical medication or not? So project then so far, as with any project and any QI piece of work, we started with a project sort of plan and brief, and how do you get to a project plan and brief is really trying to scope the problem. And although I've kind of put down further down the sort of using QI methodologies, the QI methodologies started at the beginning really to try and help inform what our project brief and plan were going to be. And one of the most sort of common things really for me to look at as in my role is, do we have a problem, and what data do we have to support what we're looking at, and what's the quality of the data. And what we found really was that we needed to kind of delve a bit deeper into critical medicines and how we figure out whether a critical medicine should have been administered sooner or not. So my colleagues within the organisation, both within informatics and pharmacy, have worked really hard at trying to look at the data that we provide. We do have an electronic prescribing system within the trust, and so we've really tried to develop a report that looks at all of the medications, the times, and that sort of scope between what is deemed as late, to really try and understand the data. And by understanding the data and having a good source of data, then obviously will then lead to other either QI projects, or if the data is really good, do we need to do anything else? So data is always key, and knowing whether that the data that you actually have is you know, reliable and been validated is really important. So that was one of the main things that we looked at the project brief and the driver diagram, to include that as part of that sort of scoping what data we have, both in electronic systems and on paper. We do have parts of the organisation, as do many NHS organisations, have part and part, where you've got some electronic prescribing and some prescribing on paper systems, and you know, how do we sort of equate both, so that we have assurances of compliance of administering and critical medicines, and obviously prescribing them in a timely way as well. So all those things sort of started off with our project brief, and then we developed a driver diagram and plan. We selected a pilot ward to test some of our theories and interventions, and we also have an ongoing group which I now chair, looking at Miss Medicines as an organisation, and we meet obviously monthly, and this obviously then had a drive within that to try and make sure that our project was being brought to that meeting and discussed. As I said at the beginning, it's been a really multi-professional approach, which has been really wonderful working with all my colleagues. I'm relatively new to the organisation, and it's been a great opportunity to meet lots of people across the organisation, and how each of us has a part to play in quality improvement. And as I said, we use some QI methodologies, so various QI methodologies. I'm quite a fan of observing practice in the first instance, to sort of just watch how everything clicks together, and so we looked at different components of the daily routine from both a registered nurse perspective, the medic's perspective, pharmacy's perspective on the pilot ward, and try to sort of look at issues that may be contributing to how, you know, critical medicines are stored, how the equipment we use to access to administer, as well as obviously knowledge of our colleagues, and testing out a few things along the way, what might work or might not work. And as I said at the beginning, really, what we were measuring and how. So it's been pretty much sort of, I think it was probably August that we first had our first really sort of validated report looking at critical medicines, and that's, you know, it's taken quite a number of months since January to that point, but time well spent, I feel, that trying to validate the data, so that when we are presenting it, that we are assured that that is actually accurate. You know, looking at the timings of somebody's sign for something electronically, that matches on the data around that same time, etc. So we're confident with the data that we're seeing in front of us, and that took, as I say, quite a lot of time to develop. So that was probably one of the biggest components or interventions that we were working on and testing. In the background, then obviously we had our pilot ward, where we looked at my pharmacy colleagues and our electronic prescribing nurse within that team, then worked really closely with the ward, looking at storage. Obviously, we've had the pandemic happening obviously during this time, and when we started this piece of work, we were obviously in our lockdown at the beginning of the year, and the ward obviously was had you know, areas of being partitions, etc., as part of our COVID plans to make sure that we were all safe. And that had a knock-on effect on storage, where we stored medications, equipment, where you maybe had the whole ward, it had been partitioned off for patients that were being isolated. So this had a knock-on effect of particularly around storage and how the staff had to try and adapt their circumstances to try and make things work better for them in that environment. And so the teams really worked really hard with around the storage, looking at stock levels. Has anything changed in the type of patient that's coming onto that ward? And that would be a learning where we're spreading that to other wards, that actually you may have a ward that's actually a surgical ward, but when we have situations like we had with COVID-19, that ward may be accepting medical patients where it would have been surgical, and the needs of those patients and stock levels, etc., are obviously going to change as a result of that. So streamlining the stock levels, looking at the equipment that we have on the wards, so i.e. our computers on wheels and where they're located and charged, and all those sorts of really practical things we looked at with the team. And those things did make a difference. And then as the years gone on, the petition on the ward has now lifted, so it was back to more of its normal functioning, which again did have a positive benefit on the end product of improving our compliance with administrating critical medicines. Other things that we looked at was around sort of the 5 whys. So why is a particular medication maybe late being given, and it's trying to scope, is it from when it's prescribed, is it supplied on the ward? Does that stock level now need to be amended to allow that to become a stock item, because we're seeing it more frequently prescribed, as well as at the administration end of, if it's not available, has the patient been transferred and it's not been transferred with the patient? Is it in other cupboards or in other drug trolleys, etc.? Is it still on the wall where the patient was before? So there's a number of components to this that obviously we looked at during the pilot. And so lots of I suppose softer interventions, as it were looked and scoped that are ongoing, and all had their part to play at different points during our time with our pilot ward. One of the other methodologies really was looking at that ward, examining whether we put out an actual critical medicines pocket guide and poster. And so we took that to the ward as one of our interventions of change, linked really around our education component of, do our colleagues know what is a critical medicine in terms of the type of drug it falls under and the impact it can have for the patient if it's late administration, etc. And so we brought a draft one to the ward, and it was really favourably received by the staff. It was, as I say, a sort of the initial draft, and we asked then, obviously, our medical colleagues on the ward of what their opinions were around it, and it was quite interesting, their response around the actual list itself. Obviously, they're very familiar with prescribing medications within that area, but it was quite interesting that they thought it would still be of benefit to have it on a larger poster size near where the doctor's station were for when they were actually prescribing, so they would just have that overall list rather than the pocket guide itself, which was not what I intended to be. I thought maybe that maybe a more visual poster or a sort of a reminder, but that they actually thought it would be beneficial to have a larger version of the poster in those days. So that kind of changed our what we were thinking. And then we also then went back and had a look at the list itself. The original draft list was split into two components, sort of list 1 and list 2. But we actually went back to the drawing board and revised it so that it was just one list, because we felt that the being in two parts might be confusing for staff. And then we took that back and actually took it back to our group as well, and was agreed formally. We also then in the background have been, obviously from a policies and procedures point of view, looking at the procedure around missed or late medications and revised that to reflect, and also made the stock levels more available on the website, so people can check across the organisation where our stocks of different medications are actually sitting to access if you don't have it on your ward or department. And also we within our actual electronic prescribing device, when you actually go in, our pharmacy teams went through every medication that is listed to be prescribed on there, and labelled it whether it was a critical medicine or not. So when staff go to administer a medicine, it will now flash up on the screen in red that it's a critical med, to help staff in terms of that actually, if you can't get it, that there's a more urgent feel to make sure that we try and obtain that medicine for our patient. So we've kind of come across it really from lots of different angles. So trying to sort of, that at the user end, that it's kind of made aware that drug falls within that group. We've also looked at our policies and procedures. We've looked at interventions locally on a pilot ward, and what we can do to sort of make sure we're as efficient as we can, and have the medications in place, and obviously that it's tidy, etc. And obviously then we looked again at our draft pocket guide that we then introduced on Patient Safety Day to the organisation. So we went on Patient Safety Day, which was the 17th of September, and we took the guides, we took the posters as our medical colleagues on the pilot ward had suggested would be also useful, and we also then had an A4 size poster that we added into or brought out with us when we visited the wards. So we ordered enough pocket guides for all our nursing colleagues, and some extra besides for our student nurses. The actual guides are, as they suggest, are pocket size. They're the size of a smartphone, and are easily sort of put in your pocket. Obviously, staff may not always have those on them, but it was a recognition how important we felt critical medicines are, and are, to increase our knowledge around them. We then put the posters up near where the doctors write any of their TTOs or medications, and near their computers, or in their sort of doctors' rooms if they were on a particular ward. And then we used our A4 posters, obviously all IP friendly, and we put those actually onto the drug trolleys or medication trolleys themselves, and were secured to those trolleys, so that staff, have every opportunity to see what's on the list, or if in doubt, they can also then check on there. The pocket guides also give reference of where else to find information, so it re-references back to the stock guide that's on our intranet pages, and obviously policies and procedures, so to really sort of link that up. And so that was kind of the 17th of September. So it's been sort of gradually growing momentum. The report that we'd been building in the background then was presented in September to our senior matrons and disseminated the first sort of version of the report in September, and then that's been reiterated and updated obviously then each month. And what we've been doing since then is obviously just sort of looking at the report itself and further validating that we can bring it to patient level rather than just sort of the percentage of award, you know, during a particular month, how many they've actually administered within the time frame expected for that critical meds, so that staff can actually, particularly ward managers and matrons, can scrutinise the data at ward level. So, you know, if it's a particular medicine, they could look for it, and if it was a particular ward or theme, so that we can start to dig a bit deeper, really. So on this project so far, also we put in, I've put there about resources. So obviously putting those resources out with the pocket guides and posters was probably one of the main things that we did and issued. But I've also then listed education there as well. So as we were going along, obviously part of that, giving those critical guides out, is about raising the awareness of what a critical medicine is, and our categories of what's listed in there. But now we'll be taking that onto the next level within the organisation. I'll just move on to my next slide. So this is just a copy of, so this is what it looks like on the outside, and then inside, forgive me, this is not the printed one. It's still got its old watermark on, but you can see on there that we have the actual type of medication, the rationale, and then some examples of that medication and terminology that will be more familiar to clinicians, to just so that it's a teaching aid in its own right. Really favourably been received across the organisation, and still got a few left, and my plan with those is just to give those to our recruitment team, so that as new registered nurses and nursing associates join, particularly that they would get a copy, or any other clinician that would want them. So so that's kind of just what they look like. And then on the next steps, then we, as I say, trying to develop that report for our ward managers and matrons to be able to drill into the detail. The report is pretty much ready, really, that we can kind of drill down to that level, and it's just now sort of working out a repository of where that will sit and access and who has access. So just the information governance around that. With the actual overall themes already, we can, or percentages for the wards, we're starting to see definite themes starting to emerge, but we've only had the report out for 3 months, and as obviously with, you know, classic quality improvement, we would normally expect to see sort of 7 points to definitely recognise it as a theme. So we will continue to obviously monitor and starting now to revise our work plan of what our next steps will be based on that. So if we're seeing a particular area with higher than expected percentages, or if we're seeing a particular medication, to try and drill down to understand the reasons why that might be, what barriers or challenges staff have got around that particular medication. And we're going to obviously continue working with our pilot ward to further test our interventions. And so it's a bit of a start of a journey, really, although we've done a lot of work and it's been successful. So we've seen a reduction of our missed critical medicines in the last 3 months. You know, and we're talking sort of small in terms of percentages, but significant in terms of actual administrations. So it's really encouraging, and part of our strategy from our chief nurse, we have a clinical system framework where this piece of work sits within that framework with an objective by the end of this year to have actually reduced critical medicines by up to 25%, and I think if we carry on the way we are, by the end of December, hopefully we'll have achieved that ambition, which is really good. So you know, it's I think for today as a change day, I think it's celebrating working with colleagues, you know, across the organisation, and when you've got really motivated colleagues that are really trying to help, it's amazing what we can do. You know, so in a short space of time, we know a lot more about our data. We've done some big rollouts to our colleagues. We're starting to see the benefits of that in terms of our results. We'll keep monitoring it, so you know that we can sort of see if that is definitely sustained now. And then the next sort of steps as well, we'll be looking at building it into our education programs, which I've seen a pilot draft last week, and critical medicines does formulate quite a significant part of our e-learning package that will be aimed at our registered nurses. So you know, it's trying to triangulate things, and there's always things to do. But I think with any project, often you start at a point where you think, and there's no right or wrong, and then as you develop over time, and things are maybe improving in one area, or you've cracked something, you then, as you learn more yourself, develop the skills or identify other themes or new things that actually become the next stage of the project. So we're kind of really at that sort of stage, waiting to sort of see if the data will continue to be positive, and if so, then we know we've actually made a significant sustainable change, and if not, we'll go back to our PDSA cycles to try and figure out why not. But our early green shoots are encouraging. So that's pretty much really what I was going to say. If you've got any questions, I'll be happy to take them.
Thank you, Katrina, for coming on today and sharing with us. That's really helpful. Looking at this, if you were to sat down with another person looking at another trust starting this work, what would be your key takeaway messages to them?
I think know your data is the number one thing, because you know, as with any QI project, I think unless you've got really robust data that you can trust and has been validated and that you are sure of, you know, it sometimes can be misleading. It could be really showing some very low numbers, and actually that's not the case at all. Or oppositely, it could be showing really high significant, you know, problems in certain areas, but actually it may be something very practical that's actually not been thought of. For example, on the system, you know, often unless the patient's physically discharged off an electronic system, often medications will then sit looking as though they're late, but actually that patient's gone home, and may have gone home for several days, but they're clocking as though they're late. And as a clinician, you know, there's often scenarios where you don't wish to administer a medication because it's actually detrimental to the patient's health. You know, so things have changed during your shift, and so maybe something that was prescribed earlier on, something's happened to the patient that now actually you wouldn't want to administer, and would be asking for an opinion and a review from the doctor. So it's trying to definitely know your data and what filters that you can apply, and our informatics teams have been fantastic. So they are overlaying a lot of our data sets around our admission and discharges. So if they are still appearing on our electronic system as being there, but actually they're being discharged off the system. They're overlaying that onto the report so that we've got a bit more valid data. And it's soul destroying, isn't it? If you've I see it all the time where we've maybe got like patients that go home from a day case area or whatever. The patient's gone home, they're fine, they've had a good experience, but if they haven't been discharged off the system, or that it's clocking, it's nobody's done anything wrong, but it's just sitting there and it looks as though it's late when it's not. So it's good governance, really, getting good housekeeping around your data. That might take time, but that's worth building, because actually once you've got your data, everything else can fall off the top of that, really, because then you can start to really home in where there are areas of things that you want to focus on.
Thank you, Katrina. Got a question in the chat. So what have been your quick wins that other trusts can share?
I think definitely the pocket guides. It doesn't have to be in a pocket guide stance, but I think definitely investing that people are. When we did that piece of work, we've obviously visited all the wards. It's kind of that big bang approach, and that raising awareness definitely has an effect. And sort of timing it with Patient Safety Day, people are of that mind frame, that particularly that day when we went out, and so could see the value of it. I think also by doing it really simplistically in that little fold out guide, it really just makes it succinct of what these groups of medicines are, and by doing so, that definitely that's a quick win for me. I think just that we kind of went out, visited all the wards, that sort of bringing something to staff. I'm smiling because like nurses really love a pen, or so we brought some pens and we brought the guides out and things like that. So people were really engaged with us and could see the value in it, and obviously so far it's starting to have that knock-on effect, but it's still quite early days. So I'm not getting ahead of myself here. I think, for sustainability, we know we've got to see a few more months' data to see but the green shoots are encouraging, and it's really nice to see.
When I was a ward nurse, quite often the critical meds were missed because we didn't have access to them. So you're thinking about your emergency PD patients and stuff. Did you encounter the same issues, and what did you manage to get pharmacists to do to help with that? Because obviously not every ward can get every medication that's on your little list, but you don't know what's going to come in through the front door.
Yeah, so part of the procedure, really, our pharmacy team have been fantastic. They have looked, obviously, sort of the processes during the day, what to do at night. I think also highlighting it on our actual electronic systems that it's a critical med has helped staff kind of, not giving them permission, but it's kind of the urgency of it. So from a pharmacy's feedback point of view, that if somebody's telling them it's such and such a medication and they obviously know that it's a critical med, they also go the extra mile. That's been the feedback from our pharmacy colleagues, that we're saying it's so critical to get, we'll try and facilitate it as much as possible to get it. So it would be maybe, if it is the on-call pharmacist, that if they can't actually locate it, giving them sort of really good advice then of, what is the alternative, speaking to the medical teams for is there an alternative that can suffice in the interim, or, what is the rationale for not being able to get it. So we have seen that improvement. Definitely my pharmacy colleagues have said that back to us, that they feel like if we're sort of saying that it's a critical med, they feel like they want to make sure they've addressed it from their end to help us. So I think it's been a really a joint effort, So I think it's raising awareness, and I think it's definitely. If we were sort of saying empowered to sort of say, well, this is a critical medicine, how am I going to locate it? I've tried X, I've tried Y, so we kind of gave them some top tips of where and how to locate it, and they're still not being able to locate it. Then our pharmacy teams, then they're that's what my colleagues are saying to me, that they've also gone the extra mile to try and locate it too, because we're all in this together and we're saying it's important.
We will draw to a close with a big thank you, Katrina, for coming to share with us today. It's been really helpful. Thank you very much. We will be recording these, so they will be shared on the Fab Academy webpage, so you may well get some follow-up from other trusts wanting to learn from your experience. Thank you very much.
Thank you for giving me the opportunity to speak, and nice to talk to you all.
Our pleasure. So